So welcome to Cancer Council Western Australia's Cancer Council Update series for 2017. My name is Melissa Ledger and I'm the Cancer Smart Manager at Cancer Council. Before we get started today, I just wanted to make two acknowledgements. The first one is that I'd like to acknowledge the traditional owners of the land we meet on today, the Noongar Whadjuk people. I'd like to pay respect to elders both past and present and offer my acknowledgement and respect to other Aboriginal and Torres Strait Islander people who are present today. The second thing I would like to acknowledge is that a colleague of ours today has passed and his funeral was today, and he would have been here today, Mr. Paul Catrice. You may have seen him if you're a Cancer Update regular, and I'd just like to acknowledge his huge contribution to the Cancer Update series as well. Today we're going to hear from Professor Ian Hammond. It's been a privilege to know Professor Hammond over the last few years. He's been leading the review of the National Cervical Cancer Screening Program, and the end of the review has happened and we're on the very cusp of the new program starting. We're so fortunate that Ian lives in Perth. We've asked him a lot to speak about the changes to the cervical cancer screening program, to GPs and community and on the media. So we're so privileged and so delighted that he's here to share his expertise. Ian's worked in clinical practice as a gynecologic oncologist in Perth for 30 years before retiring in 2012. I think he's never been busier since retiring. He's a clinical professor in the Division of Obstetrics and Gynecology and adjunct professor in the School of Anatomy, Physiology and Human Biology at the University of Western Australia. He was chair of the Guidelines Review Group that developed the 2005 NHMRC guidelines. That's interesting that the lights... It's not just me, is it? Guidelines for the management of abnormal pap smears. Last year he chaired the Cancer Council Australia Guidelines Working Party that developed the new 2016 management guidelines that will support the renewed National Cervical Screening Program. In 2011 he was awarded the President's Medal for the RANZ-COG for services to women's health. Just before the presentation begins though, I'd like to make sure that you have your mobile phones switched to silent or off. And just at the very end of the lecture, if you wouldn't mind filling in the evaluation form you would have been given when you walked in. Today's presentation is for about 45 minutes, followed by 15 minutes for questions. And we are recording today's lecture, and so the questions will be recorded, so I'll get you to put your hand up so we can get a roving microphone to you so we can record those questions as well. But that's enough from me. Let's hear from Professor Ian Hammond.
We seem to have got rid of the lighting problem, whatever the lighting problem was, so flickering lights can't be good. But Melissa, thank you very much for the introduction, and thank you all for coming out on a Monday lunchtime when you could be eating and doing other things. I've been involved in this for quite a while, and I think that Can you hear me okay? Is that all right? Stand back. Okay, great. I've been involved in this quite a while. I retired actually from clinical practice as a gynecological oncologist back in January actually of 2012. And just before I retired, I had a phone call from the people in Canberra who I've been involved with for some time, and they said, we're going to start the renewal of the cervical screening program, and how would you like to chair the committee? I said, that's a fantastic idea, except that I'm stopping work now. I'm out of here. They said, that's perfect, because you've got all the time in the world to help us. And that's really the true story. That's what they said. And when we were looking at dealing with this today and giving an update on what's happening, the title was selected actually by Terry Slevin and the team from Cancer Council Western Australia, Eradicating Cervical Cancer. Can we eradicate it? And the answer is yes, we can eradicate cervical cancer, certainly in Australia and hopefully ultimately in the world. But it's not just screening that does that. There are other things that do that, mainly vaccination against the virus that causes the problem. So what I wanted to do was to tell you a little bit about the new cervical screening test that is starting on this Friday. And to bring you up to speed, for those of you that are still having tests, then it'll tell you what's going on. For those of you that have family and relatives and whatever, younger women who were thinking about having tests, maybe this will give you some education around it. So on Friday, the Pap test, which we've loved so much over the last years, is being replaced by a new test. It's called the cervical screening test. It's actually testing for HPV. HPV is a little term for human papillomavirus, and it's the virus that causes warts that you get on your hands and your feet. It's the same virus that causes genital warts you may have heard of, and it's also a virus that causes trouble inside in the cervix. Now, there are 100 different types of HPV, and it's only about 14 or 15 of them that actually affect the cervix. Other types affect other parts of the body, the hands, the feet, and so on. So they're all different types, and it's only these specific ones we're interested in and be testing for. The other thing is that this test, when it comes into play, we expect it to further reduce the number of cases of cervical cancer and the number of deaths from cervical cancer. We've already had a very good program in this country, but we're going to improve it even further. So what I plan to do is just very briefly, for those of you that don't know, is just provide a very brief review of what is cervical cancer, just in case you're not sure, and then talk about preventing cervical cancer and looking at what have we been doing, which is basically the Pap test, and then what are we going to do and why are we going to do it? Why change, I suppose, is the thing. And then a little bit about the future. So what is cervical cancer? Many of you are familiar with this sort of picture with the cervix, and I'll just see if I can get the pointer working. I can. And you can see here, this is the cervix, the entrance to the uterus here, the womb, and this is where the babies grow, of course, and then you have menstrual flow. Menstrual flow comes out of here into the vagina. It's this area here, blown up, these cells just at the entrance, we call this the transformation zone, and it's where skin-type cells meet gland-type cells in this zone here. And it's that place where the virus gets into the cells and causes changes in the cells that lead to cervical cancer. So when you have a Pap test done, you have cells taken from this region here, and they're looked at under the microscope. Now this, of course, is what we're trying to avoid, and this is a cervical cancer, a very nasty, irregular cervix. It should be smooth and pink. And there's another one. This is in a hysterectomy specimen, and you can see the pale cervix around and this big tumour sitting there. Well, obviously, we don't want women to get to this situation where they have a cervical cancer. We want to prevent women from ever getting a cervical cancer, and that's what the idea of screening is about. Now, this is probably the most depressing slide you'll ever see, and this is the world map of cervical cancer, and you can see here the estimated cervical cancer world incidence for 2012, and nothing's changed. I mean, it's the same numbers. What you'll notice is the light colours are good and the dark colours are bad, and you'll see that the light colour is Australia and North America and much of Central Europe. The Northern Africa looks to be fantastic, but actually it probably isn't. It's just reporting is hopeless from those countries, and it probably doesn't mean very much. But Australia is very, very good. But notice that our near neighbours are pretty blue up there. There's a lot of cancer of the cervix there. And the problem is you get about 500,000 new cases of invasive cervical cancer every year in the world, and half of those women will die of it. And that's what you've really got it's a take-home message to start with, that it's a very bad disease, and it can be prevented. And it can be prevented, and unfortunately we don't have the capacity throughout the world to do this. So what have we been doing in Australia? Well, in Australia since 1991, we've had an organised approach to cervical screening, the National Cervical Screening Program. And many of you will know this, that from the age of 18 or when you start becoming sexually active, you have a Pap test every 2 years, and you stop around the age of 69, and there's a register in every state and territory that keeps tab of your results and then sends you a reminder if you're late by 3 or 6 months. You get a reminder saying, you haven't turned up, come and have a test. And that's a safety net, a sort of a safety provision to keep people going. And you'll remember the idea, those of you that may not want to remember, of course, what this is all about, which is not surprising, but a speculum is placed inside the vagina. They were always metal, now they're plastic, nearly all of them, and to find the cervix here. And that's an internal examination. And then what happens then is you can see the plastic ones, one of these brooms or brushes is taken from the cervix, into the cervix, and then rubbed onto the slide here. This slide's then placed in a preservative. which is a good idea. So you can see here it's being taken on the left-hand side, on the right, from the cervix, and that's the area we're interested in where the cell changes take place, right at the entrance. So this would be what a laboratory technician would see. They'd get one of those slides, they'd have a look at it. This is what's happening now, and these are normal cells from the cervix, normal skin cells. They look lovely, and they're very nice. Compare those with this. This is multicoloured, of course, but you can see there's a bit of a change here. The nucleus of the cells is a bit bigger. This area here is a bit bigger. But actually, these are just what we call low-grade changes, and they're due to infection with human papillomavirus. We recognise that now. But then you get to this situation where the cells, these are normal, and these are now the abnormal pap test cells. And you can see very big nuclei, very obviously different, and that's what the screening is doing when they look at the cells and they say, oh, by the way, you've got an abnormal test. That's the sort of thing they're seeing. So a woman who has those sort of cells, high-grade cells, today would be sent along for a colposcopy, and a colposcopy is where you look at the cervix using a magnifying instrument. To do that, you have to put a speculum inside the vagina to see the cervix, but you don't actually have to put that instrument, of course, inside the vagina. That would be impossible. And in fact, I once had a lecture with the medical students one Friday afternoon, and they started to describe to me how they were going to put the colposcope into the vagina. And we were sort of, having a bit of a laugh about it. So I took them down to the outpatient clinic at King Edward, and we went down there and I said, well, this is the colposcope, great big thing. I said, and how exactly are you going to be doing this? And the girls, of course, fell about laughing, and then the boys looked a bit embarrassed. Now, this is me back in 1988 doing a colposcopy. The lady was very happy, in fact, to have this displayed. But you'll see here, there's the instrument, and the vagina is up here, of course, and you're looking from outside in. And the most noticeable thing here, of course, is the passage of time, in that I had black hair in those days, and now, of course, I'm very white, which is one of those things. This is what the sort of thing you see down the colposcope. You see a cervix. This is part of the cervix. Imagine this thing going right off, miles around the whole thing. This is the hole in the middle of the cervix. This is the normal skin of the cervix. And here is what we call the transformation zone. A beautiful, beautiful photograph. And it's this area where the virus gets in and causes changes. And when you look with the colposcope and you stain the cervix with dilute vinegar, dilute acetic acid, you'll see something like this. Instead of being white, instead of being pink, it's now white. And then what you do is you identify this area, you take a biopsy, a piece of tissue from there, and you get a histological thing, and that tells you that is high-grade abnormality. It's not a cervical cancer, but it's something, if left untreated, could develop into a cancer, and therefore the idea is to get rid of it. And we just get rid of it by removing that area from the cervix. I'm not going to show you gory photographs of having it removed, because people don't really like that, but I do. The role of the register, of course, this was the program. So it started in 1991. We've been doing this since that time. Hello, Helga. How are you? Good friend of mine. We play bridge together. Come in. And since 1991, we've had this organised approach to cervical screening. And the major thing, apart from reminding everybody, is we've had these registers. And it's the registers that really underpin it all by providing a safety net. So it's really, really very good and something we should be proud of. And they act as a safety net and also provide research activities and various other things and provide monitoring and evaluation of the program. So that every state and territory has one, and the big change coming is we're no longer going to have a state registry. We're actually going to have a national cervical cancer screening register. All women will be on that register. Now, I had the good fortune in the year 2000 to be invited to chair the committee that led to this document called Screening to Prevent Cervical Cancer. So when you get an abnormality on a pap test, you've got to have some guidelines as to what to do with the abnormality. And so we have these guidelines, and that was the book that was published at that time, and that's they're called the 2005 guidelines, and it went into place in 2006. So we've been working under those for a long time. At the time these guidelines were published, the National Health and Medical Research Council put this inside the front cover. And it said that they recommend the guidelines, and they also recommend that the screening interval, the 2-year interval, be reviewed in Australia, because they thought it was a bit too much. They were going every 2 years, they thought it was too much, because the world had moved away from 2 years back then. And so they wanted the Australian government to review this. Now, that was June 2005, and I can tell you that in government processes, nothing works quickly. I mean, among the reasons for that, it's not that they're lazy, is that you need money. And the government has to pass a budget to allow this to happen. So that takes some time. So that's why it took until 2011 for them to ring me and say, we're going to start this process, here we go. We'd had lots of meetings in between, it's just they didn't have any money to do it. So what are we going to do and why? Well, in 2009, 2 years before they gave me a call, they said, we're going to renew the National Cervical Screening Program. We're going to look at the evidence around it. We're going to look at the age, the interval, the test, everything. And it took 2 more years to get there. And then we started. And just before we started, we thought we better have some aims to all of this. Of course, there are lots of policy documents. But the policy document said, if you're going to make a change to this program, which has been very successful, you've got to make sure you don't go backwards. You've got to make sure the current success stays. That's number one. The next thing is, by the time we did this, we already had HPV vaccination. You're probably aware that women in this country, young girls, can be vaccinated at the age of 12 to 13, as can young boys, and that started in 2007. So we already had 2 or 3 years of this going on, and we wanted to make sure that all women, vaccinated and unvaccinated, could access this program, and that most importantly, whatever program we're offering to women in the country, it should be based on current evidence and best practice. If you think that the 1991 program, the pap test program, which we still have right now today, is based on evidence from 1960s, 70s and 80s, it's about time we brought it up to speed with the 1980s and 90s and the 2000s. And that's really what the process is about. Now, this is just to remind you, those of you who are not used to seeing graphs, this is a graph here. This is time, 1980 to 2010. This is the incidence of cancer per 100,000 women. Before 1991, women were having pap smears, but it wasn't an organised approach. Then we had this organised approach and a terrific fall in the incidence of cervical cancer by 50%. But since 2002, it's sort of plateaued. We haven't really made any further improvement. We haven't done any worse, but we haven't done any better. You have to say to yourself, well, are there things we can do better? That's really what the program's about. You can also see down the bottom here, and it doesn't look like very much, but there's been a 50% reduction in the incidence of cancer and the deaths from cervical cancer in that period from 1991. Enormous progress. But the question is, can we do better, I think? And this is a different type of graph. What you're seeing here are 2 types of the cancers. You can see that the big, bold blue line, this one, is squamous cancer. That's one of the cell types. That's the most common type that arises in the cervix. But this one, adenocarcinoma or glandular carcinoma, you can see really hasn't changed at all during this time. And that's the one that we hope we will impact on even more when we have the new program looking for the human papillomavirus. We think that'll be pretty impressive. So it's just to show you that most of the change has occurred in the squamous cells. Now, right now, not all women in the country have a pap test. We know that every 2 years, which is the recommended time between the age of 18 and 69, about 60% of women have a pap test. But if you then take that out of it, so this is the 2-year participation rate. You can see it's down here by age of women, and it's a number. So it's not bad. It rises when they're young, they don't rush, and then in the middle age they get more and so on. But then by 3 years, you get more people participating, and by 5 years, about 80% of women in Australia will have had a pap test, which is pretty good. That's great coverage. It means that 20% of women don't have a pap test at all, and they're the very people that in fact get cervical cancer. So you can protect yourself from cervical cancer by having a pap test. The other thing that's interesting about this, I think, is that when you look at the incidence of cervical cancer in women by socio-economic group, the lowest socioeconomic group on the left has a higher incidence than the higher socioeconomic group on the right. And you can see it compared against Australia. And that's probably access to services, geography, and various things, and education that leads to that. But then when you look about remoteness of area in Australia, we've got a big country here. We don't all live in big cities and big country towns. When you look at the outer regional and remote areas, you see that they have a much higher incidence of cervical cancer than people living in the cities. And you'll see the very remote are actually better than the remote and outer regional. And probably that's because the very remote actually have very directed services to a very small number of people, the very remote. But it's quite an interesting thing, and clearly we haven't got equity across the country. So if we've done so well and reduced everything by 50%, why are we making a change? I mean, we've done so well. If it ain't broke, don't fix it. Well, the reason is we've got a lot of new knowledge about cervical cancer development. We now know the virus is very important. We've got a lot of evidence about cervical cancer prevention. We've got a lot of new technologies. I mean, many of you have had a Pap test. How many of you have ever heard of the liquid-based test or ThinPrep or SurePath? Has anybody heard of that? Yeah, it's the same test on the cervix, except instead of being put on a slide, it's put into fluid, and it's called liquid-based as opposed to a slide-based. That's a new technology. We've got all the vaccination programs, and our program is much more intense than other countries. So here's the league table, as they say, of cervical cancer in the world for 2012. And what you can see here is we have a very low incidence of cervical cancer and a low mortality from cervical cancer. Sadly, we're beaten by New Zealand, which always annoys me when I see that, but I'm pleased to say it does fluctuate up and down. But what you will notice is that Finland has the best data in the world for cervical cancer prevention. Now, we screen people from the age of 18 to 69. We do it every 2 years, and we use a cervical Pap test. They start at 30 years of age. They finish at 60 years of age. They only have 6 tests in their lifetime, and they do just as well, if not better, than we do, which means we must be doing too much to the women in this country compared with the women in Scandinavia. And that's been shown throughout the world, in fact, that we don't need to do it quite so often. Now, many of you will know George Papanicolaou, after whom the Pap test is actually named, and this is just to show you how things don't move very quickly in medicine. In 1928, he discovered the test. In 1948, the American Cancer Society said it was a good idea. 20 years, a life-saving test, took a long time. And that's good news. I think the important thing about this is not to recognise the contribution of George Papanicolaou, who was a Greek immigrant into the United States. It's to recognise the remarkable contribution that his wife, Elena, made. Elena had a vaginal test taken every day for 12 months. So if you think you're having it tough every 2 years, she deserves a medal, doesn't she? And really we should show her a photograph. But the point being, it was Papanicolaou and his wife together that did the testing that showed the changes in the vaginal skin. And he was looking for just hormone changes in the skin, in the vagina. And by accident he found these cells and then realised he had a stain and a test that would make this happen. So it took a while. Then in 1982, Harald Zerhausen from Germany made this remarkable bit of experimental work and discovery. He showed that the human papillomavirus was actually necessary to develop cervical cancer. So that was a whole new thing. And of course that took a while to be accepted, and it took till 2008 for him to get the Nobel Prize in Medicine, but a very well-deserved Nobel Prize in Great Research. Now we know that the human papillomavirus affects everybody, and it even affects elephants, as you can see there, some very nasty genital warts in an elephant on the right. But what you see here particularly is that some types, these are the types that are associated with cervical cancer, and types 16 and 18 account for over 70% of all of the cervical cancers in the world. And in fact, in Australia, it accounts for 78%, so more of those types. And these are the types that will be included in the testing which we look for things. The important thing about this, though, is that 16 and 18 are included in the vaccine for cervical cancer. And you'll remember Ian Fraser, Australian of the Year, developed this vaccine with a Chinese colleague, Zheng Xiao, and this came into place in 2007 for girls and 2013 for boys, and it has 4 types of HPV. It has 6 and 11, which causes genital warts, which is a nasty thing to have. It doesn't kill you, but you don't need it. And 16 and 18, which cause cervical cancer. So it's a fantastic vaccine, and it's been shown to be incredibly effective. And so in Australia, I'm grateful to Julia Brotherton from the National HPV Register for providing me the slides. But this is national Australian data, and you can see this is in girls aged 15 years, the coverage in 2016 for 3 doses, and you can see got a pretty good coverage around the 80% mark across the board. The Territory has a very big program going, and they did very well. And you can see that boys, a bit less, the boys haven't taken it up quite as much, but still very, very good across the country. We're doing very well with our vaccination program. And what you can see here, and this is the only technical slide I've got to show you, but I think it's quite interesting. In here, you see 2007 here is when the vaccination program started. And this is the number of precancerous abnormalities on the cervix, which you actually treat to get rid of cancer. That's what you find from screening people. And what you see here is you look at this one for under 20-year-old girls here. So under 20 years, just after the vaccination program started, these high-grade abnormalities started to disappear. And then a few years later, the 20 to 24-year-old disappear because they're just getting a bit older. And then the 25 to 29-year-olds start to disappear. And just now we're seeing, right here, in 2015, a fall-off in the older women. As they've got older, then the vaccine effect is shown. This vaccine is a game changer in this country. It's totally fantastic. And genital warts have almost completely disappeared, completely. So this is the algorithm that just shows you the development of cervical cancer. You've got a normal cervix, you add HPV, you get an infection. If you're happy to have a pap test at this time, it'll show some abnormal cells, and we tell people to go away and come back in a year and have it repeated again, because this virus, 98% of these viral changes will disappear within 5 years, and 80% will be gone in a year. That's why we don't send people straight to colposcopy right now when they have low-grade changes on the cervix. But a small proportion of the patients, the virus will get into the cell nucleus, become integrated, and cause potentially cancer-causing changes, potentially. And it's these women you're trying to pick up by finding these abnormalities with these cell changes. And some of these will go away, but if you wait for 10 to 20 years, they'll get a cervical cancer. So the idea is do a pap test every 2 years, find these abnormalities, get rid of them, and they won't develop cervical cancer. We can prevent that, of course, by using the pap test, HPV testing, and getting rid of the abnormalities. And over here, we use vaccine now to prevent it. And if everybody had the vaccine, we would see very little of this disease. And so the combination of understanding about the virus, the new liquid-based cytology in the top right, and the vaccine lead us to a renewal. So what we did, and I won't go through this in detail, but just to tell you that over 2 years we looked at all of the evidence available about the tests that were around. We compared everything to what we do now. So what we do now, or are still doing, is a pap test every 2 years in this age group. We compared conventional cytology with a new age range. We looked at liquid-based cytology with a new age range and a 5-year interval. And we looked at HPV testing. We looked at safety, effectiveness, and cost-effectiveness. And there are 132 different algorithms were looked at by the modelling people that did this. And in the end, they came up with a recommendation, if you like, evidence that went to the Medical Services Advisory Committee of Australia. And 3 years ago, they produced a report saying that we should change our program. The evidence was overwhelming. And they said we should change to an HPV test with what we call partial genotyping, looking for 16, 18 particularly, and then use this pap test, if you like, or the cytology on the liquid-based sample to look at the cells only if we find HPV. Because if you haven't got HPV, you're not going to have any changes in the cells. So they're doing it the other way around. And 90% of women who have this test will be negative. They'll be going away and coming back in 5 years. It's only a small proportion where the laboratory will look at the cells in the ones where they find HPV. They're going to move a new interval, 5 years instead of 2 years. We're going to start a bit later. We're going to finish a bit later. All women will take part. Self-collection is an option for women who've never been screened, and I'll come to that in just a minute. And we'll have a national register, which I think is an amazing way forward. And this will lead to up to 30% better results. 30% less cancer from now, 30% less deaths from cancer from now, which is very powerful. So in a summary form, we're changing from a pap test to an oncogenic HPV test. Oncogenic just means cancer-causing. We're going to change from 2 years to 5 years. We're going to choose from 18 to start at 25. We're going to finish a bit later. We're going to invite people to take part, not just remind them to take part. And there will be the opportunity for self-collection for some women. So briefly, what I'd like to do is just outline for you the test, the interval and the age and why it's safe. Because you might be worried about it. You might think, well, I've got a new test. I don't know if it's any good. I don't know if I like the idea of 5 years. I think 2 years is better. And, whatever it may be, you may not be happy. And I'd like to try and help you. The new test is so much better. The new test, the HPV test, is so much more sensitive. It's 95% plus sensitivity as opposed to 40 to 70% with a pap test. That's why you keep doing it every 2 years. In case you miss it this time, you'll get it next time. When you've got a test that's 95, 96% sensitive, you can do it every 5 years because it's so much better across the board. It will allow for the early detection of high-grade abnormalities. It'll prevent more cancer, and it's got the potential to remove that glandular cancer, which would be very good. But what's really interesting is if you don't have HPV, you are good for 5 years at least. You will not get cancer in that 5 years. I mean, it may happen very, very rarely, just like a pap test today. You may get something in between, but it'll be very, very rare. So it's very protective. What about this 5-year interval? Are we happy with 5 years? Well, you're probably not happy with 5 years. We've spent 25 years telling women they must have a test every 2 years. So why would you suddenly think it's okay every 5 years? And some people have said to us, well, I think they're trying to save money. And I can tell you that there is no money involved in this change, in the sense that it was never part of the deal to save money. It was part of the deal to find the best possible test with the best arrangements, and that's where it came from. It's not to do with money at all. In fact, the money, it'll be cost neutral, the whole thing. It won't save any money. But what I wanted to show you here was this, and this is quite an interesting graph. It is a bit of data, but it's quite interesting. This is a study where a lot of women started here at 0.0, and this is months, and at this point, it's a European study, massive number of women. They either had a negative pap test or a negative red HPV test. And then we followed them with time to see what abnormalities they developed. And at 2 years, the normal pap test interval, what you can see is, let's just say 40 per 10,000, it doesn't matter, 40, and number 40 had an abnormality, not cancer. But if you look at what happens with HPV testing at 5 years, half the number of women at 5 years had an abnormality compared with this number of pap test patients at 2 years. Meaning that the HPV group, the test using that test, was much more protective, and in fact it was twice as good as a pap test every 2 years, which I think is pretty compelling. And there's also another study that actually showed very much the same thing, but this time was looking at cancer across the whole of Europe, 4 very big randomised control studies put together. This was 0.0, and you can see here that if you had a negative pap test, it took 2.5 years before you started getting abnormalities. But if you had a negative HPV test, it took 5.5 to 6 years before you got abnormalities. And you can see here the conclusion that at longer intervals, 5 years, HPV-based screening is 60 to 70% better in protecting people against cervical cancer, which I think is pretty compelling. So, what about the age? We've been telling people they've got to be screened from the age of 18, and now we're saying it's okay, don't worry about it, come when you're 25. But of course, girls that have been screened at 18, 19, 20 now, I suspect will be a bit nervous about this. But in the future, hopefully the education process will get through. And I just wanted to show you a graph which is interesting. This is cervical cancer in Australia. This is not anywhere else in the world. This is from the best data from the Australian Institute of Health and Welfare. This article was published last year, and what you can see here is the 3-year incidence. This is date from 1983 to 2010. This is the incidence of cancer. This is all cancers, all types, all ages. And you can see that when the program started in 91, we start to get a nice fall in all types. The red ones are the squamous ones, and the blue ones are the glandular ones, and they haven't changed at all. But if you look at this by age, your eye is immediately drawn to the left-hand side of this screen, where it's completely flat for the women who are under 25. Screening women under the age of 25 has had no effect whatsoever on cervical cancer incidence in this country, none at all. Whereas older women, older being from 25 up, start to get the fall, and older women still a very dramatic fall in squamous cancer, but you can see the glandular cancer has had no change. And this leads us to believe that screening women under 25 is just basically a waste of time. You're going to cause more harm than good. And so the ultimate overview of this is that 25 years of screening in Australia, younger women, has had no impact on cervical cancer at all. A review of all the literature for our review showed no impact in other countries, all countries. We know that we have a very low incidence of cervical cancer. It's not to say we don't have any cervical cancer in these young women. Of course we do. We have about 4 to 15, 16 new cases of cervical cancer in women under 25 every year. The real issue is, does screening make any difference to it? And the answer is the pap test has made no change in these numbers whatsoever, which is Sad, but true. And finally, the World Authority, the International Agency for Researching Cancer, in 2004 made a statement: we should no longer screen women under the age of 25. It is more harm than good. Because if you find an abnormality in a young girl, very, very common in these girls, and you treat them, you run the risk of damaging the cervix and therefore producing either infertility or premature loss of babies in the mid-trimester. In other words, not good for pregnancy outcome. So what does it mean for GPs and most importantly for you? Well, it means they're going to stop taking the ordinary pap test. For you as women, you will still require an internal examination and the test to be taken from the cervix, but for the GP, they will put it not on a slide, they'll put it into a little bottle of liquid, and that gets sent to the laboratory with the details, and the laboratories will tell the doctors what to do. For you, you need a speculum examination. I know many women at meetings I've been to, they always put up their hand and say, can we just have a skin test or a blood test or anything but this speculum examination? And the answer is no, because anything else is not quite as good, but I'll just come to that in a minute. And they'll still have a sample taken, the test will go off. If any HPV is detected in the sample, the laboratory will automatically look at the cells. We call it reflex cytology. They'll look at it automatically. You don't have to go back for another test. And you'll get a result from your doctor, and all your results will be kept by the National Register. So the doctors will get a report saying you're either low risk, intermediate risk, or higher risk. And what does that mean? It doesn't mean higher that you're suddenly going to get cancer. It just means you're a little bit higher risk than the average woman in the population because you've got HPV there of getting some changes in the cervix. That's all it means, nothing else. And you've got to be looked at. So the laboratory will produce a report telling you what tests have been done, and it goes to the doctor, and it will continue to make a recommendation for follow-up. So if your test is negative, if a woman goes in and after December 1 or on December 1 and has a test done and it's negative, no HPV, you'll be asked to come back in 5 years, and you'll get an invitation in 5 years and a reminder if you don't turn up. If your test shows HPV 16-18, the one that accounts for most of the changes in cancers, you'll go straight to colposcopy to be examined by the specialist gynecologist. And if it's HPV of the other 12 types that are there, but the cytology is abnormal with liquid, high-grade or low-grade change, you'll go for colposcopy, and that'll be recommended. But there will be a group, just like today when you have a low-grade abnormality, they'll be asked to come back in 12 months, and they're called the intermediate risk group. As women, you don't need to worry about it particularly because you'll get the advice from your doctor, but it's quite nice to know that what it is about, and there is some information about this in the brochures that are outside. And when you come back at 12 months, the good news is that if there's nothing there, you go away for 5 years instead of messing around every year having a pap test till it all gets back to normal. But if there's anything abnormal, you go along to be seen. So the HPV test is the primary test, and then the cytology is done if they find it, and from there you move forward. It's a much, much better test. It's much more streamlined. Of course, it has meant that in the laboratories, the women, mainly women, who were the technicians that looked at all of these slides over the last 30, 40 years, there's no need for the same number of staff anymore because they will not have the same number of slides to look at. And so there's been a massive change in the workforce in the laboratories, and the very women and men who have made the difference to cervical cancer screening are now effectively unemployed, which is terrible, really, in the laboratory. Many of them are being retrained, actually, into other areas, but what they spent their lifetime doing is no longer needed. So the sort of report that might come back to your doctor will be something like this: had a thin prep specimen, test results, nothing found, rescreen in 5 years, and you'll be told to come back in 5 years. Or it might come back with a little red flag saying, look, there's higher risk, not terrible, HPV 16, not much on the cytology, but send them along for a colposcopy with a specialist and see what they find. And they'll probably find very little and probably say come back in 12 months. Or you might be the yellow, the intermediate risk, in which case they say just repeat the test in 12 months. So there's this range of things. Come back in 5 years, come back in 12 months, or go to see the colposcopist. It's really, nothing much has changed from now. This is a very complicated slide, and I'm not going to go through it, but this is available to doctors, really. And it just tells them the pathway. You have the test here, these are the possible results, and every doctor's received a pack in the last 2 weeks, every doctor in the country, and the nurses that do this program, and they have got these sort of information to guide them in the way forward. Now, I mentioned at the start self-collection, and self-collection is misunderstood, but is very appealing, because what self-collection is you don't have to have a speculum put inside the vagina. So there's a lot of, enthusiasm for all of this. The problem is it's not for everybody. We know that 80% of cervical cancer arises in women that have never had a Pap test or are very overdue by 3 or 4 years for their Pap test. So they're the women we should be worrying about. What we actually worry about is we worry about all the women that have tests and how to manage them and what to do. They're the ones that are protected, quite honestly. They're not going to get cervical cancer. The women that don't have them, if we all went out right now into the street and asked every woman you met, have you had a Pap test? And you found that 30 of the women hadn't had a Pap test, and you managed to convince them to go in and have a Pap test, you would have done more to save life in 10 minutes than we're probably going to do in this talk over 45 minutes, because you get someone who needs to be protected who isn't. So this is the indigenous cancer incidence in this country. These are women who are notoriously underscreened, Aboriginal women, Aboriginal and Torres Strait Islander women in the country. And this is an older slide, but it holds good. A recent study was done in Queensland by Lisa Wapp of the Menzies Group, and she showed that if you look at screening across all Aboriginal, this is in Queensland, if the average in Queensland was 55% of women had a screening test every 2 years, in the Aboriginal and Torres Strait Islander community it was 35%. So these women are underscreened, severely underscreened, and they have twice the incidence of cervical cancer. They have 4 times the death rate from cervical cancer that we have in the basic Australian population, and that is because they don't go early for symptoms. They leave their symptoms until quite late. So what is a self-collection? What does it mean? You can take a test using a small swab. You would have taken a swab, been to a doctor and had a small swab, like a red-tipped thing, a wooden stick with a little bit of cotton on the end, and they take a swab, like you have an earbud or something like that. So it's a long one. You take that from the lower vagina. We use it now for testing for all sorts of things around the body, ears and noses and everywhere, throats. This is the same sort of swab. It gets popped into the lower vagina, about 3 or 4 centimetres, twiddled around. You do it yourself. Put it in a tube, you give it back to your doctor or the nurse at your practice. It's not not sent to your home. You do it at the practice, and they send it off and they look for the HPV. If they find HPV, you will need to come in and have a proper sample taken from the cervix. But if it's negative, you come back in 5 years. So it's very compelling for women who, for various reasons, will not have a speculum examination done. It's not quite as good as the routine test, because the vagina doesn't have quite the same viral amount that the cervix has. So it's better to get it from the cervix, but it's absolutely better than nothing. And it's approved by the government because we hope to improve the participation rate in the screening program. But it's not as effective as a proper doctor sample, if you like, or nurse sample from the cervix. But it's much more effective than the current Pap test, and it's a lot more effective than having nothing at all, and that's why we want to get something for these women. But it's only available to women who are documented never to have been screened or are overdue. And if they are not that, they will have to pay the full cost of the test, which is expensive. Otherwise, it's covered by the Medicare rebate. Ultimately, in 20, 30 years' time, this may be what everybody does. Maybe what everybody does. But right now, it's restricted. And there's another pathway for self-collection. Now, some of you in this room may have had an abnormality in the past 12 months, something, you're under follow-up. All that happens to women that have an abnormality is they've been told to come back, let's say in February or March or April, May. They just turn up in the usual time. And then instead of having a Pap test taken, they have the new HPV test taken. So whatever appointments you've had and told to have, just keep the usual appointment. You'll just have a slightly different test. And that's all that really matters for those women. So, what about the big ticket items? The budget for the National Cancer Screening Register was approved in May 2015. It goes live on Friday. It won't be quite as functional as we'd like it to be on Friday, but it will be recording all the tests, and by March it'll be able to provide all the invitations and the reminders that we need. In the meantime, the state registers will continue to run while this is in transition. But the important thing about this, as I've highlighted, every woman in the country will have one record. So if you are here and you move to Victoria, your record will be accessible. So you don't have to worry about it, the doctors don't have to worry about it, everybody can find out what's been going on, so you make a proper recommendation for you about it, and then it's appropriate. What about quality and safety? Without going through the details, there is a very robust government committee that will look at all quality aspects and safety aspects. So they're monitoring all the time to make sure that the results are appropriate, the testing's appropriate, very heavily monitored. And David Roder from South Australia will be chairing this, an absolute tower of a man, and very, 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 very good indeed. We have new guidelines, and I had the privilege of chairing the committee that developed these guidelines. When I did the old guidelines, the 2005 guidelines, we were told at the time this would take about 18 months. So I accepted it back in 2000 to do it. Of course, it took 5 years. I mean, nothing ever takes what you think it's going to take. This crowd turned around and said, would you mind chairing this group again? I said, not for 5 years, I'm not. There's no chance. Forget it. They said, no, we've got fully resourced, government-backed, 9 months. And if I tell you, it was 10 months. Could not believe it, because we had all the resources to do it, and it was absolutely fantastic. Plus, I had a fantastic team working with me from New South Wales Cancer Council, Cancer Australia, and a lot of clinicians. So these new guidelines are available. I won't say they're particularly consumer-friendly. They're written in English. I mean, they are written in English, which is a good start, and they are understandable, and the recommendations are all there. And by all means, if you want to go there, you just go to the Cancer Council Australia website, and you can get a link. You just dial up cervical screening and you can see the guidelines. If there's something interests you particularly, by all means go and have a look at it. And perhaps even the Cancer Council WA will have a link to this on their own website. I don't know. Presumably you will. Yeah, they will, which will be very good. I have that on my phone, in my iPad, everywhere. I just can't go anywhere without it. But what does the future hold? We've got a great new program, a great new test, a new age, a new interval. We're going to have 30% better results. It's got to be good, and it's starting on Friday. But what is really the future of all of this? Are we going to be able to eradicate cervical cancer? Well, I think the eradication is achievable. And I went to a talk the other day by Julia Brotherton, who's the medical director of the HPV vaccination register running out of Melbourne. And she produces some very complex slides, and she's an epidemiologist and statistician, and she says, I think these are very difficult slides. So when she says that, there's no point in me showing them because I don't understand them, you see. But what she told me, the new vaccine is another game changer. The old vaccine with 4 types of HPV is good. The new vaccine has 9 types. It's been approved by the TGA, Therapeutic Goods and Administration in Australia. It will come into place next year. It'll be rolled out in the states and territories, depending on how the states and territories do it. It's nationally rolled out, but individual states do it separately. And you can see here, this is our current vaccine, 6 and 11, genital warts. That removes 90% of genital warts, 16 and 18, 70% of cervical cancer. And now we have these other HPV types, 31, 33, 45, 52 and 58. That's another 20%. So 90% of cervical cancer will be prevented in women that have this vaccine. It starts next year. And the amazing data is that if you give this vaccine, and it's only 2 doses, by the way, not 3 doses. Right now it's 3 doses. Now it's 2 doses, starting at school age. And what's amazing, at 12 to 13 years of age, if you were to vaccinate 80% of girls in the country and 80% of boys in the country, we will not have cervical cancer in 30 years' time. Just by vaccination alone, gone. So it's really, really impressive. So vaccination is the end point, I think, of getting it done. But we need the screening test while we move forward and carry on. So I'm hoping that the combination of the vaccine and the screening test will lead to the eradication of cervical cancer. I'd like to say that when we meet again, well, I won't be here, of course. I shall be in other places, I'm sure, by then. But I'd like to think that this number of 250,000 dead women every year in the world from cervical cancer is gone. And if I knew how to do Photoshop, really knew how to do Photoshop, I would have wanted to do the whole map in this colour, so that we didn't have any cervical cancer anywhere else in the world. But world politics and the economy of various countries does not allow this to happen. But hopefully, in the times to come, we will see this happen in our lifetime. So I'll just remind you that apart from Cancer Council Western Australia, their own website, the National Cervical Screening Program has a terrific website with a lot of consumer information if you wanted to get it. Much of it is available here for you to take away today. But there's a great little video, and I'm not going to play it, but this is the video. It lasts a couple of minutes. It's really quite fun to watch about cervical cancer and prevention. I gave me a bit of a chuckle when I watched it, but I'm easily amused. So thank you very much indeed for your time today. happy to take any questions, no matter how simple they may seem. If they're concerning you, very happy to answer a question. If you have a microphone at the back, have we got a mic? Who's got the microphone? Here it comes. No microphone. Shout out the question, I'll repeat it.
With vaccinations, I know they're available for school-aged children.
Yeah.
Are they available for women in their 30s, 40s and 50s who never accessed them previously?
Sure. So the question is, you know that vaccinations is available for school-aged children and is paid for, government paid for. Is it available for older women? Is it? Well, the answer is yes, it's available, but not free. So if a woman suddenly woke up tomorrow at the age of 35 and said, oh my God, I must get this vaccine done, or the new vaccine's here, I want to go and do it, of course you can have it done, but you have to pay for it. And the dosage is, I don't know the rate actually, I heard mentioning the other day, they were talking about the cost, because of course it's not available yet, the new vaccine, but they reckon it'll be about $150 a shot for 2 shots. But if you look at that in terms of, say, for example, a woman was sexually active in her 30s, which means she would be, and she's meeting new partners, she does run a risk of getting genital warts, for example. Well, I think if you're protected against genital warts, that's a great start. And by the time you've had medical fees to go and get those sorted out, you know, that's well over 300. And so it's safe, but really you're getting protection against cervical cancer. So I think if a woman wanted to do that, she could. The problem is that a woman who's been sexually active from, say, the age of 20, or the mean age of commencing sexual activity in this country is 16 years and 1 month. So 50% of women have started having sexual activity at 16 years, basically. So it's quite dramatic. And by the age of 20, it's about 90-95%. It's very, very high. The odds are that women will be in contact with those viruses, those types of viruses, as they move up. So the vaccine may be less effective, if you like, if they've been in contact, but no reason why not to have it, let's put it that way. There's no test you can do beforehand to find out whether it's okay or not. So good question, thank you. Yes?
Two questions, if you don't mind. One is, why did these tests stop at age 74?
Yeah.
Everyone else does this,
No.
And the second question, if you don't mind, two at once, is I get why you want to vaccinate boys. What do you tell boys?
Oh, okay. What marketing tool do we use for the boys, you mean? You mean how do we sell it to the boys? Is that sure? Well, they just love the girls. No, that wasn't the reason. That wasn't what they said. Okay, the first question, my memory's hopeless. What was the first question?
Why does the test stop at 74?
Yeah. Well, the point is that older women actually are more likely to get cervical cancer than younger women. So when you look at the age range, I mean, I showed that graph which showed the young women, basically the screening had no effect. But at the ages of 50, 60, 70, 80, you can get cervical cancer. And in fact, the age 50 to 60, 70 is quite high. Now, if you're screened regularly up until the late 60s, the chance of you getting a problem in your 70s is very low. But we're going to stop at 74 because the incidence, if you've been negative all that time with the test, the chance of you getting cervical cancer then is very, very low. To which some women have said, well, what about if I meet a new partner at the age of 71, 72 and get a new virus, and maybe that will cause changes that will give me cervical cancer? Well, it takes 10 to 20 years to get the changes into cancer. And in terms of a public health program, it's not a valuable way to spend our money. I'm not saying it couldn't have effect on certain individuals, but it's not good for a public health program. The way that got the boys going, we realised that girls were the major thing with cervical cancer. We wanted to protect the women. But we also realised if you can get boys vaccinated, you get rid of the virus in the boys as well. It's not circulating in the community, and therefore you get a herd immunity. We call it herd immunity, that more and more immunity occurs because you've got more people who are immune to the problem. And so you get a multiplying effect in the community. There's also, boys do get genital warts, and we didn't want them to suffer from genital warts, and there are cancers, particularly of the mouth, the larynx and the back of the throat, and anal cancer that is related to HPV type 16 and 18 particularly. That wasn't the reason to institute the vaccination, but it's a good selling point across the board. Does that answer your question? Okay, thank you. Another question. I saw a hand. Yes, please.
I don't know about the figures, but if the HPV virus is
Sure. It's a very good question. Because the HPV is so prevalent in our society, does that mean we're going to find much more HPV when we start this test and therefore more women are going to be tested? Well, the answer is yes, and you've raised actually a really, really very important point. It's one that's hard to get across, but when you have a very sensitive test like we have here, and you suddenly take the whole population and you put this test out, on let's say on Friday, all the women in the country rush off, which they won't be doing, I'm quite sure of that, but they all rush off and say, wow, let's have one of these. And when you do the test, you'll find they'll have a lot of positives because they've only been tested by Pap test before, which is not that sensitive. But on top of that, the test will lead, because it's so sensitive, to finding some early cancers. And the cancer rate in the first 2 or 3 years of testing is actually going to go up. We know it's going to go up. We've predicted this already. And, of course, the newspapers, when they get hold of this, they'll be saying, rising cancer in Australia coincides with new tests. So their spin will be, we haven't got the old test, therefore the new test is no good, and therefore we've got cancer, except the new test is so good that it's detecting early cancers, and we'll be able to protect those women by treating the cancer for a start, but also many more women will be detected having abnormalities that could lead to cancer. So your question is very, very good. It will lead, actually, in the first few years to increased, not just testing and retesting, but hopefully the retesting, they'll go away, the virus, but would also lead to the investigation of women. So colposcopy, the test we use looking, and that will be increased probably in the first 4 to 5 years by about 20%. And all the states and territories' public hospital services have been alerted to this. Most colposcopy is actually performed in private practice. 70 to 80% of all colposcopy in the country is performed privately. It doesn't mean you don't have to be privately insured to see a gynaecologist as an outpatient in their rooms. It only really impacts you if you have to go into hospital to have treatment. And nearly all of the treatment is carried out actually as an outpatient under local anaesthetic in rooms. So it's pretty good. Having said all that, it will be a rise in that. You're absolutely right. But in 5 to 7 years' time, it'll be back and go under the amount that it is now, because vaccination's continuing. All the time in the background, there's this slow train of vaccination going all the time in the population, and that is reducing and reducing and reducing the abnormalities. And you talked about prevalence. If you took women under 25 today, at any one point in time, 25% of all women under 25 have got HPV. So it's pretty common, very, very common. Any other questions? Yes, please.
When should a woman have her first cervical screening test?
Okay. When should a woman have a first cervical screening test? Well, as I said, in the old days, until Thursday of this week, I would say from the age of 18. But as of Friday, at 25 years of age, or when sexually active. I mean, there are women that are not sexually active at the age of 25, and if you're not sexually active or have ever been sexually active, then you shouldn't have this test at all. And the only thing about sexually active, I mean, for most people in the room, that would mean having sexual intercourse. But it doesn't always mean that. We've got gay couples who are having intimacy, skin-to-skin contact, and the virus can be transmitted. It can be transmitted by sex objects that are placed in the vagina and may have contacted HPV. So different groups can be susceptible, but any type of what we call genital skin-to-skin activity is sufficient, and those women should start at the age of 25 or when they become sexually active. Is that all right? Answer the question?
I actually meant how long after my last pap smear should I wait?
Oh, that's after your. Oh, well, that's the. Well,
that was a great answer.
But I prefer my answer actually. But how long after your last pap test? Well, I'll give you some examples. If you're over 25 now, whenever you were due to have your next pap test in 2 years' time, you just turn up and have the next test, and they'll do the new test at that time. And then if it's negative, you'll come back in 5 years. If you're 21, 22 now, you'd normally be coming back, say, at 23, 24. And that's no longer part of the program. So these women who are younger, what's going to happen is they're going to get, because the registers know they had a test, they're going to have a letter from the National Register to say, you were due to have a test on September 2018, because it was 2 years from your last test. But actually, the new program suggests that you don't need to have this, and we will write to you again when you're 25. Now, some of these women, I think, will be a bit confused by that because they're part of a program and they sort of suddenly the program's been taken away from them and so we'll come back in a couple of years. That will require a bit of discussion with their doctor. If they were really keen and said, look, I want to have it anyway, I don't care, I'm going to have this test, I'll have it now, they can have it, but they have to pay for it. So it's not that we're stopping people, you can't stop people from doing things, it's just the government won't pay for it. The majority of women, if they understand the process, will appreciate it's okay, and particularly if they've had a normal test. I should say, though, if they've had an abnormal test under the age of 25, they will be followed regardless with the usual follow-up procedures, because you can't say to someone you've got an abnormal test, forget about it and come back in 4 years. I mean, that's not reasonable. So I hope that answers the question. Yeah. Keep the usual appointment is the story. And yes, please.
I'm the current president of a volunteer group called AIM, Gynecological Awareness Information. I'm sure you're familiar.
I remember Kath Mazzella, of course, very well, yes.
Now, we have come across a small percentage of women in the public who have a perception that the HPV vaccine is the cause of their daughters having HPV. How do we change that perception in women?
So the comment really from the president of GAIN, which is Gynecological Awareness Information Network, isn't it? Yeah, that's right. Is that there's some concern among some members of the community that the HPV vaccine is actually causing the HPV changes in young women. Well, I mean, the only thing one can say is, of course, that's nonsense. I mean, that's the first thing, but that doesn't help because, I mean, people don't like that sort of response. I think although it's true, of course, and under our breath we go, oh my God, really. However, when people have misconceptions and misunderstandings, it's our role to educate. I mean, that's really the story. So I think all you can say is, when the vaccine is composed of what's called virus, this is what I would say to people in your group anyway, it's composed of virus-like particles. It is not composed of human papillomavirus. And that's why the achievement of Ian Fraser and his colleague Jean Zhao is so amazing, because they developed virus-like particles, and no one had ever done this anywhere in the world for vaccines, because nearly all the vaccines that we use, as I'm sure you're aware, are either live vaccines which are attenuated, or they're killed vaccines, but they're from the virus, whatever it was. This one isn't. It doesn't have any virus in it. It has a little bit of the capsule of the virus. It's not possible for the vaccine to actually produce an infection in anybody because it doesn't have a whole virus there. All you can say is tell people what it is, why it's not possible, and they still probably won't believe you, truthfully. But all you can do is tell the truth, and you can't convince people, actually, if they don't like the story. Are there any other questions? Yes, please. Yeah, all they have to have, yes, they will. All doctors have to have is exactly what they had before, except they have the same equipment, but they have to have the little bottles, if you like, for liquid-based samples in their practice, rather than having slides. If you went to see a doctor on Friday, by the way, any of you, don't rush on Friday, I think it'll be chaos, and Friday's not a good day, but if you go on Friday and your doctor pulls out a slide, one of those old slides, and starts to use it, you have to say, stop. You mustn't send this. 2 reasons. One is, it's old and we're not doing this anymore. They might get a bit upset with that. But the one they will relate to is you say, I will have to pay for it if you send it, and I'm not paying for it, so don't send it. Do the proper one. Because as of Monday, no laboratory will get a rebate from the government for sending a slide in. And they don't want it. And I'm sure I know that the laboratories have been very active in telling their doctors and nurses in the various practices, change over. They've had them changing over for the last few months because they can't bear the thought of these slides coming in for many reasons. So that's the answer to the question, really. Yeah, they're ready.
I think we'll have to leave it there.
We have to leave it at that, so I'm going to hand over to Melissa. Thank you.
All right, thank you very much. Thank you very much, Professor Hammond, and I was going to say please join me in thanking him, but we've just done that. Please don't forget to complete your evaluation form, and also just a reminder, the Cervical Cancer Prevention Program WA is also out there with a stall. They've got lots of information on the new program, and it's definitely worth picking up a brochure on your way past. Thank you very much.